afternoon, everyone, and it is my pleasure today to be here with you, although I can't see you, to talk about pharmacy in Canada over the past 20 years and the evolution towards a more customer-based, patient-oriented type of service that we're providing. On the next slide, I'll just provide an overview of what I will be discussing with you today. Like to talk about where you can see pharmacists represented, talk a little bit about the pharmacists. And this ties into a lot of how we evolved and the practice and effect on policy management. As you can see on the next slide, wonderful map of Canada that shows where we're located. We're bordered by 3 oceans. Neighbor to the United States south of us. And we're actually not that far from Greenland as well as Russia on the other side. It is a vast country that is home to over 38 million people. And we have 10 provinces and 2 territories plus Nunavut. Nunavut is that yellow area on the map north, heading up towards the Arctic Circle. So the important part about this is that you may recognize Canada as a country. We have a prime minister who oversees and responsible for our direction and looking after our country and diplomatic relations and many other functions. But each province has a leader, and each province has a premier who is responsible for taking care of that province and or territory and looking after the budgetary aspects. So the important part of this message is that in order to establish policy, we have to do it separately in each jurisdiction that we're governed by. The interesting part about Canada is, in these provinces and territories, we're very diverse. Geographically, you have the Atlantic and the coast on that side. Quebec, as I'm sure many of you know, is largely francophone, great province, very European-like. Love Quebec City. Ontario is very diverse in economies of scale. The people, the 3 next provinces are the prairies, mostly wheat, cattle in Alberta as well as oil, and then the far west province of British Columbia, which has the majestic Rocky Mountains and probably the warmest spot in Canada right now. It's important to talk about the vastness, the connectivity that we have, the different jurisdictions, but we also have diversity in people. Canada is home to a lot of people from all over the world, and I'm one of those people. I'm an immigrant. And right now we welcome various people from various parts of the world. So we have many different languages in Canada as well. And that will come into play later on in the presentation when we talk about servicing our patients, our citizens of Canada. And just point out that of the 38 million people, most of them are in Quebec and Ontario. Ontario has a population just under 15 million and Quebec just under 9. Ontario definitely is an epicenter for a lot of things. And once again, that factors into the influence as to what drives change as well. So when we talk about diversity and representation in Canada, on the next slide, I'd like to share with you how many pharmacists we have in Canada. We have a total of 45,000, just over 45,000 pharmacists in all of Canada, spanning that wonderful territory. And out of those 45, just over 43 are practicing, which means that they're found in other settings, that difference. We have a group called licensed pharmacy technicians, which is a relatively new position, and that's evolved over time. They're pharmacy assistants who've taken on a higher level of responsibility. So they've taken on some of the technical aspects the pharmacist has been doing, which gives pharmacists time to do more work. And in terms of total pharmacies, we have about 11,000. Hospital pharmacy number is not fully represented accurately because not all provinces license pharmacies in hospitals. They fall under that hospital domain jurisdiction. So that's why there's that discrepancy. Actually, even in Ontario, it wasn't until the late 90s that we actually were governed under a regulatory body of for compliance and standards and so forth in Ontario. So that means that in a country of 12 jurisdictions, 2 territories and 10 provinces plus Nunavut, we have actually 12 pharmacy schools, 2 in Ontario and 2 in Quebec. And each jurisdiction has their own licensing body. So if you're licensed, say, in Ontario, you want to go to BC, you want to enjoy the climate there, you actually have to get relicensed. So it's not transferable. So that's the uniqueness of the country. We are a country with many different almost like little countries as a result. On the next slide, just a breakdown of where you can, once again, the representation of pharmacists throughout the country. No surprise that in Ontario, we have the highest volume of pharmacists is in proportion to our population. And we even have pharmacists in our Canadian forces. And I actually graduated with someone who is an officer in the Canadian forces. So a lot of uniqueness in terms of where we're found, what type of locations, the geographies amongst where we work and what we do. So speaking of where we can be found, this is a breakdown on the next slide of the different settings where pharmacists can be found. Community pharmacy is by far the largest. That is was termed as the corner store. The retail pharmacy has had many different terms over the years. And in that setting, you can find about 66% of pharmacists in all of Canada. What's also interesting to note that in terms of the makeup of pharmacists, most pharmacists are women, actually. And it's a great point to mention today on this day of Women in Science and Pharma Conference that about 80% of pharmacists are women in Canada. We graduate about 1,200 students annually out of all our faculties of pharmacies across Canada, and 1/3 of the practicing pharmacists are internationally trained. So what that means is that there are people who finish pharmacy in other countries and have come to Canada to start a whole new life. And so that brings to us into our pharmacy settings a great deal of diversity in different cultures, different languages. That's a huge advantage. It's an advantage in that our pharmacists mirror what our Canadian citizens look like in languages. Language is important to note, and communication is important. And to communicate how to take a drug, to be able to answer questions, to make people feel comfortable. Sometimes we talk about language barriers in Canada, and that would happen if, for example, for me, having to deal with someone who's from Asia, not well versed in that language, unfortunately, but having colleagues who are is a great advantage. And it really, you can see the ease that it puts patients in. I definitely have had the opportunity to use my language skills. Да, говорим hrvatski и можем се разговаряти с пациентом. So for me, it's been nice and it's been heartwarming to be able to help people where maybe English isn't their first language. And I certainly understand that journey because English is not my first language. and being sympathetic to people and being respectful in the workplace of people that have religion or practice religion different from us. When I was a director of operations for pharmacy, we had people who, say, for example, were Muslim and had their prayer moments, and they were given a space, and they were allowed to give a space. It's become very natural in Canada, actually, to see this diversity. And I also have to share with you a personal pride that as a hiring manager, I've hired a number of immigrants. Once again, it's a soft spot for me because although I was very young when I came here, I still remember the journey, and I still remember the difficulties and feeling foreign because of language. So I'm happy to say that I to have contributed to that face of pharmacy as a hiring manager and given people an opportunity. In regards to our settings and where and how community pharmacies broken down to, yes, the most common is the one that's open to the general public, accessible 7 days a week mostly. We do have long hours, so that it does help people get their medications around their work. It gives them flexibility, convenience, and in that community setting, there's others. There are some pharmacies that only service what we call long-term care or nursing homes, retirement homes, very different. They're close to the public. There's specialty pharmacy, which can be those pharmacies that provide biologics and pharmaceuticals that require special handling care, unique products, as well as compounding pharmacies. So we have lots of commercially available product, but sometimes some products need to be made. And one area what's most common is in hormonal products for women, very specific dosages and preparations that are prescribed to mimic the natural hormones of an individual. Not to say just women, but that's predominant, but also men with hormonal challenges as well, and a few other products that cannot be found on the market. So they're also unique in terms of they're almost like a production site. And then there's pharmacists in something called family health care teams. So a while back, we've evolved into creating a setting of multidisciplinary in the community, sort of like the hospital. And pharmacists have been added to that team, and they interact with the physicians. They will see patients there as well, and they will do medication reviews in that setting. So that's also a unique position. And hospital, which I know there's a lot of pharmacists in hospital in Croatia, that role has become largely clinical, integrated with the physicians and teams, highly specialized. A long time ago, when I worked in hospital, I developed a specialty in geriatrics. My love, moje babe dede. So paying homage to my grandparents in a way, that's where I lean towards. And of course, we have pharmacists in academia, research, insurance companies, consultants. I was one of those at one time, working with our clients. In that case, it was employers who were providing a plan to people, and we were providing them insights and a lot of other information, helping them manage the drug spend. And of course, in corporate roles. And the nice thing to note here is I've seen a lot more women move to much higher senior levels in the corporate world, in pharmacy corporations over the past, say, 15 years or so. So that's another, I think, change in where women have excelled as well. And some pharmacists choose to be consultants in different areas. So a lot to be said in this area, but my pride comes to sharing with you the diversity in where we are and where we work and the opportunities that can be found. And I certainly am one of those people who has enjoyed those opportunities. In terms of the structure, what does a pharmacy team look like, be it hospital or community setting or any of those specialty settings? There's always someone who's a leader, a pharmacy manager or owner if it's an independent pharmacy, and there's a pharmacist or several pharmacists. So I reference that we work long hours, or our stores are open long hours, and we're open 7 days a week. Well, one pharmacist isn't necessarily going to work all those hours. There could be 2 or 3 pharmacists that split up the shifts and cover the pharmacy that way. The law states that no doors can be open without a pharmacist on the premises. So it's important to always have good staffing. We have pharmacy assistants in retail or community pharmacies. They're predominant are supportive staff who process prescriptions, fill prescriptions, help answer phone, serve customers when picking up prescriptions, and a number of other tasks. The pharmacy manager is ultimately answerable for everything that goes on, and that is the level that our college or regulatory bodies actually hold the pharmacy manager to. The pharmacy technician category, they're licensed, they carry liability insurance like a pharmacist. They do take on more tasks, as I mentioned earlier, of the technical duties, and they actually have really grown in the hospital area. And it was probably mid-90s or thereabouts, or sorry, mid-2000s, where the hospitals totally switched out to having that classification. And that definitely has enabled pharmacists to be much more involved in the care of patients as part of teams and various units. And then there's sometimes other staff, clerical staff, that help out and support us. So I'm just laying the groundwork for you and some of the roles and eventual changes that are happening as a result. On the next slide, just a little bit of an overview on the types of pharmacies. It's interesting to note that 66% or 64% of our pharmacies are represented by corporate. So the pictures on that slide show you some of those corporates, and some of them span across the country and have that presence, and others are more local, like Lawton's. Lawton's is down east in Canada, and London Drugs is predominantly Western. But Shoppers, Rexall, The Guardian is a banner. Actually, it's pharmacies who buy into that program to support them through marketing and other aspects, and also through drug ordering and defray their cost that way. I remember, I've been around long enough, when we used to order direct from manufacturers, pharmaceutical manufacturers, and the minimums were, I don't know, if $1,000, if that. Well, that changed dramatically. I remember when it went from no minimum to 1,000 to 10,000, and now our drugs mostly come through a distributor. The biggest one in Canada is McKesson, and so the formation or buying into a banner helps an independent survive that way. It's much more cost effective for them to do that than try to be on their own. The other interesting area where you're going to see pharmacies is big box like Walmart. Walmart, not sure if there's any in Croatia, but they have a very strong global presence, and they're our leading global retailer, and they have diversified in terms of their offerings within that big box, and one of those is pharmacy, as well as they have clinics, medical clinics, and optometry. So there is a medical component. It's a one-stop shopping. In our country, I've shared the vastness of our land. Distance is an issue. I grew up out in the country. The corner store was a 5-minute drive, not a walk. So providing people services that make it easy for them and convenient is an advantage, and Walmart is definitely one of those places. The picture on the bottom, it says Loblaws. It's actually a grocery store, and we have pharmacies in grocery stores. That's about 15% of the pharmacies can be found in that setting. So can you imagine something like Interspar, who with a pharmacy? So those are some of the unique models and setups that we have in our world of pharmacy in Canada, as well as the others that I mentioned. And even the hospital pharmacies have an open outpatient pharmacy, because most pharmacies within a hospital are for the service of the inpatients and looking after them in the drug distribution and other services. But they've opened out outpatient pharmacies where they provide prescriptions to people that may come to clinics, to the staff in the hospitals, and they may also use that as a venue for providing investigation drugs. And that's actually flourished quite a bit over, say, the last 10 years. When I was at McMaster University Medical Center, that was one of the leading ones that started this model and did not have great uptake. The people who work in the hospital wasn't convenient. They prefer to have the pharmacy close to home, so there's that, distance issue again. And so it's interesting to see how well they've done. They also do compounds. So we have a number of children's hospitals. Sick Kids is the most famous, I think, of all of them. And because the pediatric dosages have to be created for the very little people in those hospitals, they also compound, and they have the formulas and create the formulas and that sort of thing. So a lot of diversity in our pharmacies as well in terms of services and what could be offered. And some of my colleagues have become truly creative. We have a pharmacist who's actually openly, well, a number of them that are openly gay, and they actually have built a practice around this, helping patients with AIDS, which is really amazing. And there's so many examples of these unique niche services that people have created. So that's a little bit about that scene. So on the next slide is the rushing waters of change. So up until, well, probably the early 2000s or so, thereabouts, pharmacy was pretty simple, pretty straightforward. It was about giving people product, a lot of very personalized, one-on-one sort of conversation with people. Not a lot on the knowledge, not a lot of focus on having an impact on people's health. And so in the next slide, just talk about the fact that we have great healthcare in Canada, and so from that perspective, we're living longer. And I think other parts of the world, especially in Europe, you can certainly agree with that. And an aging population, however, also has an impact on our healthcare system and the cost of the healthcare system. It's great that we're living longer, but for example, you can see an average of 9 prescriptions, and that might be a low estimate in people that are in nursing homes. And we've also seen at a younger age what's termed here as lifestyle illness, which is your cardiovascular illness, diabetes, so cholesterol, hypertension. And that started much earlier in time than in past generations. So once again, more people on drugs. And more cancer, and the evolution of pricey cancer drugs on the marketplace, once again impacting the funding models in our country. The other one, which some of you I know in the audience are with pharma, you're going to find interesting, is the advent of the biologics. And once again, I believe this is a global matter. I remember being at a talk early 2000s when a rheumatologist was presenting on Remicade, and I was at that talk was to a group of what we call private payers. So insurance sort of associated individuals who manage the budgets of spend for drugs for their customers, which are employers. And learning about the mechanisms of action of Remicade, and you're like, wow, this is so cool, and this is going to like make a profound difference in people's lives. And then you hear about the cost of it, and it was like, okay, 50, 60,000 for years treatment at that time. That was only the tip of the iceberg. There's a lot more biologics, and now we even have biosimilars in Canada, and they're becoming much more prevalent. And even last night when I was working in pharmacy, speaking with a patient, they're talking about being on one of these for their cholesterol management, and he's like, wow, it's making a profound difference, and it's costing $300 a month. In Canada, it's pretty expensive for a prescription, I will tell you that, especially when we have a high level of genericization. So what's evolved out of the increase in biologics on the marketplace is the specialty pharmacy. Remicade, once again, is an infusion type of medication. So these specialty pharmacies are special in handling of these products. They also have infusion settings beside the pharmacies that are run by nurses. The other factor that came into play is Health Canada. Actually, a number of years back, with an antiplatelet drug called ticlopidine or Untitled, which is a precursor to clopidogrel. And Health Canada was wanting to see more monitoring on post-market surveillance of drugs, and especially something that is like an antiplatelet. And so that has come into play more and more. And with the biologics, they were wanting to see more support of patients. Some of these products are self-injectors. How does the patient know what to do? Monitoring of their effectiveness, monitoring of their side effects, and being there, being available. So these specialty pharmacies have become quite interesting and complex settings now. And for example, when you work in retail, you may not even see this part in terms of a patient's product. If they have Remicade, you're not going to see that in retail. Even someone with the other auto-injector products. We're okay with that. We have enough focus to take care of other things. So that's, once again, an interesting type of pharmacy that has evolved. The other part of the patient support programs that is present also is the maneuvering of finding reimbursement. So reimbursement for these products can be difficult. Health Canada approves a product when submitted on its merits and clinical data, scientific data, so on and so forth. But then each province decides where it's going to sit in its formulary. So it doesn't mean that it's open market. And like I said, when you're looking at sometimes $100,000 for annual treatment, province is going to think about where that's going to lie. And sometimes there's a tiered approach, or most of the time it's a tiered approach. So for example, like Remicade, you have to show that your disease was not managed, controlled with an NSAID, or non-steroidal anti-inflammatory. So there are mechanisms and levers in terms of who pays for it. And that's also on the private side. They also have those mechanisms and levers. So the patient support program also helps patients to maneuver through that. It's very complicating and very complex, and so to have this group developed is very supportive and helpful to patients to get treatment. Then on the next slide, where what also has been driving our change in our profession is our leaders in pharmacy. What's interesting to note is I graduated, about 30 years ago. And at that time in pharmacy school, I was told I was going to be counseling patients, I'm going to step behind the counter, I'm going to be more interactive. Well, when I graduated, that wasn't the case. It was a very foreign concept, actually. Well, our leaders in pharmacy have been working with different levels of government. On the national level, we have the Canadian Pharmacists Association, and every province has an association. So they're developing relationships and have developed relationships with the governments and other stakeholders like physicians groups, nurses groups. We work very collaboratively in healthcare to look after our patients and to work on the shifts. So pharmacists or advocacy groups have moved us from that symbol, the black mortar and pestle symbol, to the green symbol, from being dispensers of product to dispensers of knowledge. And that's really important to note. And on the next slide, just want to share the outline of the complexities of how we're paid. Pharmacy, for most part, is actually private business. We operate in a social covered plan healthcare system. So hospitals are covered by public coverage. So the province covers for hospitals, physicians, labs, and prescriptions for certain groups. Seniors generally get coverage, as do other people who may be low income, may not have work. So there are different opportunities for support for healthcare provincially, but that's also variable. I'm in probably the richest province, and the funding, the support for healthcare is great. The economies of scale are also a factor. So down east, not as strong. So there is funding that's available. It may not equal Ontario. Private coverage employer programs. So if you work for a company, most cases in Canada, full-time employees get some form of support towards healthcare. Drugs are part of that, has other services like dental and chiropractor and so forth. So basically, pharmacist prescriptions, as outlined next slide, are covered in somewhat same manner through all the payers, be it private or public. So once again, it's based on prescription, it's based on drug costs. We should get paid for what we pay for a drug, and the MU stands for markup, and a dispensing fee to equal total drug costs. Not always do we get paid absolutely everything equally, and those have been some signs of levers of change. So from that perspective, the Ministry of Health, for example, in Ontario, will pay a dispensing fee of $8.83 for senior prescriptions, whereas if you're cash paying, then it's $11.99. Or third-party payers have also used this as a lever to decrease costs. But going back to our advocacy, we don't feel that that is a great representation of what we contribute, and that we do contribute in other ways that impact the well-being and care of our patients. And the advocacy side is leaning towards reimbursement for cognitive services. And so on the next slide, I'd just like to share the slide. I'm sorry, it's a very busy slide. It represents all the provinces across Canada and where we have certain authority in our scope of practice and what we're able to do. So to get the scope of practice at play, it's a lot of conversation with various stakeholders. It's a lot of conversation with the College of Pharmacies. And what I mean by College of Pharmacies is the regulators. So are the pharmacists able to provide that? Are they trained? What's in place? What needs to be done to get there? As you can see, the province of Alberta is checkmarked everywhere. You can do anything and everything in Alberta. But important to note there is that they have different levels of pharmacists in the community. They have clinical specialized pharmacists who are able to perform a number of these functions. And one unique function they have is that pharmacists there can interpret labs and request labs for people. So for your diabetics, if they think they haven't seen their doctor for 6 months and they write for A1C lab. So that's an example there. But their system is unique in that they have access and visibility to the full patient profile through the public health system. In Ontario, we do not. I believe it's in the works. And then there are different aspects of that. It's a complex system to put in place when you're thinking about protection of privacy of individual information. So in Alberta, they've been able to do that. Our pharmacists definitely have change in terms of numerous specializations, even certifications in the retail setting. A lot of pharmacists are certified diabetic educators. I mentioned myself as having background in geriatrics, respirology, pain management, drugs, like I said, AIDS drugs, travel medicine. There's numerous specialties that we've gone down and are represented in our pharmacies, not just in hospital, but in the community. And I have talked to, this slide a little bit. I was ahead of myself when I spoke to the different scopes of practice that we're able to perform. And on this slide, it gives you a big view of that and speaks to the differences that we have across our country. Once again, the different jurisdictions that we have in the process that one has to go through each time we want to bring something forward. And on the next slide, the most significant part of that is really exciting, is we actually are getting reimbursed. So when I go back to that reimbursement piece of what we've done, and just getting reimbursement on a prescription, we are also getting reimbursed for our services, and that's major. And you can see once again, the Western provinces are funding a number of different services. Now, the important aspect of this is that we have been able to show the economic value and the impact on patient lives and care to get that. It didn't happen. We had to show value. We had to show impact. We had to show quality of life indicators to be able to get that coverage. So it is a honor that we have, and we and as a director of operations at one time, I was involved in driving this change towards increasing pharmacists' shift from being totally dispensing focused to now being patient interactive and being involved in utilizing these services, which we fought for very hard over decades. On the next slide is just an example of one of the first ones, and that's a comprehensive medication review, which we get reimbursed for. In different provinces, that structure of payment reimbursement is different. So the importance of this is that when patients often come to the pharmacy, it's a one prescription interaction. Okay, Petra, you have gotten a prescription for an antibiotic. Go through all that, what are the side effects, what you expect, and away you go. However, this gives an opportunity to talk about their whole medication profile and bring into any non-prescription medications that they may have, and opportunities to see if they're adherent to their treatment, opportunities to see if they have any adverse events or any other issues that might come up. Last night, I did some of these, and the patient confessed to me that they have reduced their cholesterol medication and they haven't told their doctor. And it's like, oh, okay, interesting. So this also gives us that opportunity to share with physicians these findings, and we do bring it up to the patient and say, okay, so I'm going to share this with your physician, or some other findings I have. So it actually takes it out of their equation to have to contact their physician. We do it on their behalf and help to improve their well-being through findings that we found. The next exciting hallmark event that happened was something I had the opportunity to participate in, and that was the reimbursement of cognitive services for pharmacists in smoking cessation. So at that time, I was working for what we call a third-party payer, or someone who manages the cost of drugs and other services on behalf of employers. And every year in January, one particular employer would allow their employees to get covered nicotine patches and nicotine gum. In January, we all just want to make ourselves feel better, improve our health, lose weight, stop smoking, and get fit all at the same time, right? So basically, what we realized, that they just said, okay, people, now you can have your patches, your nicotine gum, whatever, to help you stop smoking. But it really wasn't an effective approach. It just, you can buy it, but if you smoke, and I don't, but I know it's a difficult change and it requires guidance. And studies have shown that through counseling, coaching programs, people are much more successful. And through that process, we identify people who are actually going to engage in the process. So in this program, we worked with one large employer who actually was interested in paying a fee for pharmacists, not just for the prescription or the product, but for actually the service of sitting down with someone. And on my side of the fence, so it was a pretty interesting project where we basically had to work with the employer, develop the program, reach out to pharmacy groups that service the employees of this program, which are also spread out geographically, have a conversation with them on what this process is going to look like. And then on the backside, I work with IT to develop how the payment process is going to look, because there are so many interventions. And I hate to tell you, when you work at the insurance side, people are always looking for fraudulent practices. So we don't want overbill. We want to make sure that they follow the program. And it was a very successful project that resulted in improvement of outcomes and savings actually for the employer, but more importantly, well-being, impacted the well-being of their employees. And this, in the next slide, not only was it for this one employer, but this program was adopted by other provinces, Ontario, as well as Saskatchewan and a few in Manitoba. And it's really incredible that they took this on, and it just shows the value that pharmacists do bring to the table through spending time with patients, and what an impact we can make on people's lives. So the next initiative that we undertook as pharmacists, and I was actually in an interesting position here as well, where I was the director of pharmacy operations, and in 2007, the Ministry of Health in Ontario announced that they are going to allow pharmacists to provide influenza injections. Our College of Pharmacists allowed that in terms of the regulations of the college, and we were allowed to provide IM injections, and it was very specific for influenza vaccine. So this happened in the spring. Oh, that doesn't seems far away from the fall. We had to make sure that every single pharmacist was trained on injection training, and through that, it was also required that we have first aid or CPR training. We had to make sure that we were compliant with public health requirements in terms of the fridges and the process. And so that all had to be set up. and we had to send in applications for each single pharmacy to be allowed to be granted the permission to carry publicly funded vaccines. So that's the also first of its type. The publicly funded vaccines can usually be found through public health, through doctor's offices, so those areas that are funded by public health. And so there's a lot to do. And we were very successful. And I was working for a company at that time that was a leader in pharmacist-driven vaccinations of influenza. And that was in 2007. And here we are in 2022. So it's become common practice now. Every year we go through the same process. And it's interesting to see the changes for me and where we're at now. There was definitely resistance from pharmacists. I can tell you that during this process, because it's like I did not go to pharmacy school to be an injector. I personally am not crazy about needles, but have adapted to it quite well. The key facets why we were granted this is for accessibility to patients, to our residents, in getting vaccine. Uptake was not great before that. Also in '99, the flu season was horrible. A lot of hospitalizations, a lot of people that were very sick. And up until that time, the policy was to only vaccinate people over 65, immunocompromised, pregnant women. It was very skewed towards selective populations. And after the flu season of '99, that really changed health policy, because then they just opened it up and basically looked at it from herd immunity, immunization for the protection of everyone. And that's where they needed more access. And because of the hours of operation in pharmacies, people working, they needed that availability. And public health still provides it, but we have been able to do a lot more. The other part of that, in terms of the effectiveness, also the cost effectiveness on the healthcare system, that is improved. As I mentioned, '99, a lot of hospitalizations of people that had severe illness from the influenza of that time, and this keeps people out of hospitals, and it allows people to go on with their regular daily lives, and it protects the vulnerable better. So our impact in our difficult journey initially has proven to be very successful and very impactful on the well-being of our residents. So that leads me to current state. And interesting to note that time in 2007, we would have never known to what degree we're going to be involved in having an impact on the wellness of our citizens. So when the pandemic hit, it'll be like three years almost now, next month, it certainly had an impact on all of us, all our lives, no doubt. And for us professionally, it had a great impact in the changes that had to be put in place very quickly. Pharmacies never closed during this time. We might have changed our hours. Sorry, Petra, I changed slides. We were there through it all. Our hours might have been minimized for safety. We've seen changes in capacity. We've evolved into a new concept of curbside pickup. So keeping everyone safe in the building and our staff. So when someone called and they said that they're part of a family someone has COVID, we became creative very, very quickly, where we negotiated with people to say, okay, you can drive up to the outside, don't get outside your car, I'll put the prescription in the passenger side for you, so there's no contact. Money payments were handled through credit cards. There's more of that. It also, for some pharmacies, it required re-engineering of their systems in terms of e-commerce as well. We were there throughout it all, managing patient needs. Our other colleagues, physicians, were shifted to telemedicine. Once again, safety of mind of people not coming, not increasing exposure. So a lot of adjustments, a lot of PPE. I've never worn so much PPE. Plexiglass came down at counters, increase in sanitization, new process, new procedures, constantly adapting and changing faster than we ever had to. And in terms of our scope of practice, we were able to, up until this point, extend or renew prescriptions. So for maintenance medications like cardiovascular and whatnot, if it made good sense, we were not able to get a hold of a doctor, we were able to renew. Well, Health Canada and our respective colleges, pharmacy, now switched that over to controlled narcotics, to decreasing any barriers to care. Transfer of narcotics prescriptions to other pharmacies was not allowed before. Well, they enabled that. And the mere fact of that, and I've seen myself firsthand, where a person might live in one city or town and work in another. And when people had to stay home and weren't working, well, now getting to their pharmacy was difficult. So we don't want to put that barrier up. So that was definitely one of some of the very dramatic changes. And those abilities to transfer narcotics and control drugs and to renew the prescriptions, which I've actually used that authority with certain discretionary guidance and judgment. For example, when mom calls and their child is going to run out of Concerta, the ADHD medication, they're not going to see the specialist for a few days. I wrote the prescription for that. So you don't want somebody to not take it. That is not in the best interest of the patient. So those are some examples of that dramatic change and managing supply. Can't say it was that horrible in my experience, but we were also limiting to 30-day supply. In Canada, it's more common to provide 90-day supply in general, and just to make sure that everyone fairly received their medications, we were for a very short time actually, providing 30-day supply medication. And then the vaccines came. And we had to learn new systems. There is a program called Covaxone. I think it's actually global. And that's where we had to learn so that whether it's a pharmacy who's providing the vaccine injection or someone in the public health realm, nursing, we all could see it. So people had fluidity of where they could get their shots in convenience. And our mandate was and still is to support our population, whether they have a health card or not, as long as they have valid ID. So if they're a new citizen to Canada, we definitely support them. They have the documentation and help them. And if people have received their first dose in another country, public health supported that. So we learned to provide the vaccines. We supported that. It's been I'd say a collaborative approach in terms of supporting the vaccination of our citizens between us and public health. Initially, in the first startup, it was through public health, through hospitals, and then it opened up to pharmacies. We also have been involved in doing some testing, and I see that with hesitancy. Non-symptomatic travelers, and the reason for that is that we don't want someone who's symptomatic come into the pharmacy where there are vulnerable people. The testing sites provided by public health are generally a hospital. They're segregated from the remainder of the hospital, so it was not increasing the risk. And even as I speak to you now, we are participating jointly with the government of Ontario to disseminate 5 million rapid antigen tests a week through pharmacy. So we're rolling out free testing kits to people so that they can self-monitor their health and well-being. And I'm proud to say that Canada, in general, has a total population, has vaccinated up to 80%. In some jurisdictions, that's higher. And we've also rolled out third doses. So this is the end of my presentation. Hope I did not speak too much. A lot of actually complex points in all of this that could use more time. And I'd like to thank the Ambassador Canada and the woman Adria for this amazing opportunity. I wish I could see you guys. I just see my presentation. Hopefully some point in time I will be able to come and visit, and I hope to meet some of you. Puno vam hvala. Drago mi je da sam ovdje s vama danas. Više mi je drago nego vi znate. I sada, ako ima nekakva pitanja, ne znam kako to će se organizirati, a možete postaviti vaše pitanja.